Hello and welcome. I'm Jeunesse Castalgay, VP at Clarus. Our team is thrilled to see so many of you join us here today for the live webinar, Pragmatic MSK Ultrasound, scanning the rotator interval, common extensor tendon, and patellar tendon. Over 2,000 clinicians registered for today's event from over 30 specialties. You're among physical therapists, orthopedic surgeons, primary care physicians, emergency doctors, pain management experts, sports medicine clinicians, chiropractors, and dozens of other experts in a variety of fields. Welcome to all of you joining us from all corners of the world. Clarus and SonoSkills have teamed up to bring you today's educational webinar. We'll be joined shortly by renowned educator Marc Schmitz, who will teach us anatomy, sonoanatomy, technical scanning skills, and pathologies common to the shoulder, elbow, and knee. You'll learn MSK ultrasound scanning skills that you can use on your next patient to make a confident diagnosis and expedite the right treatment plan for a more rapid recovery. But first, let me introduce you to your host. Dr. Oran Frankel is trained in emergency medicine in California, has been using point-of-care ultrasound his entire career, and is a passionate POCUS educator. He now practices in a busy academic teaching hospital in Vancouver as an emergency physician. When he's not saving lives, Dr. Frankel also serves as chairman of our Clarus Medical Advisory Board. Welcome, Dr. Frankel.
Thanks, Jeunesse. It's good to be back. And today's topic, I want to jump right into ultrasound imaging of orthopedic injuries and the musculoskeletal system. You know, ultrasound imaging is incredibly powerful for MSK, and it can really be sometimes an alternative, but also often the primary diagnostic tool in many musculoskeletal injuries. And with ultrasound becoming increasingly portable and readily available, we're finding that the ability to diagnose is really spreading into many more avenues of medicine. You know, as we did this background research, we really found it's across the board that ultrasound really can, and we know in clinical practice, diagnose everything from fractures and dislocations to tendon and ligament injuries. In our shop in emergency medicine, it can guide fracture and dislocation reductions, and we can use it in regional anesthesia and pain management, which we've done other webinars on. You know, and ultrasound really, we're alluding to, it's become the primary diagnostic tool for many traumatic, inflammatory, and degenerative soft tissue conditions, not only because it can make the diagnosis on the first visit, but it can also be used to monitor the condition with ongoing measurements and ongoing reevaluation of those patients every time they come into the clinic, and with quantitative measurement, even being able to track progress and improvement or deterioration in those patients. And what we know is that the applications are quite broad. So really, every one of us clinicians sees patients with MSK pain and injuries. And beyond just orthopedic surgeons, we have emergency physicians, general practice physicians, physical therapists, really everyone who sees patients with musculoskeletal complaints. A lot of the times the attention is focused on radicular pain from the spine and head, and the extremities often get overlooked. And part of this is because the diagnostic abilities are pretty limited to just clinical and physical exam. But what we know is that with the improvement of ultrasound technologies, our ability to make these diagnoses in the office or in the clinic or even in the hospital have really become significantly improved with allowing detailed evaluation of soft tissues and beyond to the ligaments, tendons, and the nerves themselves. So before we jump into today's content, I want to see, you know, we're all in this together. We all face these musculoskeletal concerns in our patients. And I want to do a quick poll to see that we're really encountering a lot of the similar challenges in our clinical practices. So please click all of the ones that apply to you. And which of the following have you encountered in treating musculoskeletal concerns and your ability to diagnose and treat them? Have you encountered too broad of a differential diagnosis where there's too many options of what could be causing patients' pathology and it's hard to pinpoint the specific pathology? Have you experienced a mistaken diagnosis? We as clinicians make our best guesses and we have to follow those, but often these can be inaccurate without better diagnostic testing. And then this can lead to ineffective treatments. Have you experienced misguided or misdirected therapies requiring extra visits to your clinic or office practice, and maybe even experiencing lack of improvement or even worsening in a patient's condition with the wrong treatment? Have you experienced unclear progress? Seeing a patient over and over again with subjective reporting, it makes it difficult to ascertain gradual progress where it can be measured in percentiles with quantitative determination, but we have a hard time doing that in the clinical practice? Or have you experienced complacent patients without an apparent lack of results and is subject to reporting? Have you experienced that patients experience a lack of motivation or lose the drive to put in the work they need to and ultimately end up with suboptimal results? All right, let's close out the poll here, see where everyone landed. Yeah, so really across the board, tough time narrowing the differential with diagnosis and treatments and progress as a result. So we can see that we're really all in this together and experiencing these very real challenges. And to get us more up to speed on how to integrate ultrasound, we can't think of a better person to invite to join us than our expert guest speaker, Marc Schmitz. Marc completed his MSc at the Faculty of Medicine and Pharmacy at the Free University in Brussels, and his interest in functional anatomy grew tremendously while dissecting and studying cadavers. It was here that his interest in observing functional and human anatomy in real time peaked, which led to the start of embracing musculoskeletal ultrasound. After completing numerous courses and attending conferences on the topic, he started developing his own course, and SonoSkills was formed in 2010. Since then, SonoSkills has taught its courses in 30 countries. Marc's team consists out of 22 expert trainers, and he teaches, next to managing SonoSkills, the foundational course and some intermediate level courses. He has a special interest in the shoulder joint, and we're so thrilled to have him join us today. Marc, I'm going to hand it over to you.
Yeah, thank you very much, Aaron. Good to be here. Thanks for the invitation, and thanks to the audience at home. So what I'm going to do is we're going to speak about the rotator interval, the common extensor tendon, and also the patellar tendon. And this we are going to do to make you better sonographers and to enhance your sonoanatomy and also some sonopathology. And let's also increase the technical scanning skills. So as Aaron already mentioned, I'm the founder and trainer at SonoSkills, but my clinical work is actually based in the Laurentius Hospital in Roermond, a city in the Netherlands. And there I work in the radiology and orthopedic department. So let's go to the rotator interval and especially the sonoanatomy, because what is actually the rotator interval? So the rotator interval is situated in the shoulder, in the superior anterior shoulder, in between the supraspinatus and the subscapularis. So this is a zone where there is no rotator cuff, and in this zone we can find three structures actually. This is the long head of the biceps tendon, this is the coracohumeral ligament, and this is the superior-glenohumeral ligament. And pathologies which you might see in this region could be signs of tendinosis of the biceps, biceps instability, could also be a frozen shoulder or problems with these ligaments. And this is a structure, or this is a region which in most standard protocols is not included, and this is the reason why I also wanted to discuss this today with you, because I adopted this actually as a standard practice, and it brings me always quite a lot of information. So this is a cross-section of the rotator interval. And here on the left side, you can see the lateral actually side, the supraspinatus tendon, and on the right, we can see the subscapularis. And in between, in the middle, we can see the long head of the biceps tendon. And this long head of the biceps is stabilized by this coracohumeral ligament, which is wrapping like an envelope around the tendon and is a small but important structure. Right next to the biceps tendon, on the medial side of the long head of the biceps, we can also find the superior-glenohumeral ligament. And this is also a structure which is more involved than people usually think. So it pays off to check this. So let's go to scanning, how to scan this. And we are going to place the transducer on the ventral shoulder in a little bit of a diagonal way. We are going to follow the biceps up to proximal. It curves around, and then there you are going to place the transducer. And what we are going to see actually is this long head of the biceps tendon on top of the humeral head right there. And the long head of the biceps is indeed stabilized with this superior-glenohumeral ligament and also this coracohumeral ligament, which is actually crossing or topping the biceps. Superficial to the coracohumeral ligament, we can find the bursa, the subacromial subdeltoid bursa, which cannot be seen right now because this is a healthy bursa. But if pathology is there, then definitely you can see an effusion within the bursa. We could also do, next to the static imaging, we could do a dynamic imaging. So what I'm going to do here is I'm going to take the patient's arm, bring it into an extension, and I'm going to move his shoulder in extension, but also internal, external rotation. And what we want to see actually is that the long head of the biceps is actually following the humeral head. So we don't want to see counter movements. This we don't want to see, because that would mean instability of the biceps, and this would mean a tearing of the supportive structures over there. So it's not only about cross-sectional scanning. What we could also do is longitudinal scanning. But I think that to start, I would always choose this cross-sectional, because this gives a nice overview and also a better understanding of the anatomy.
Marc, do you always stand behind the patient when you're scanning the shoulder like that?
Well, that's the, let's say, the Anglo-Saxon way of scanning. There is the Mediterranean way. You see, at least in Europe, in Spain and in Italy, you can see a lot of scanning from a ventral approach. And in England, Sweden, the Netherlands, we have this posterior approach. Both are okay as long as that the output is normal. Okay, so let's go to the next slide. Let's go to the sonopathology, because if we scanned the long head of the biceps, the coracohumeral ligament, and also the superior glenohumeral ligament, how do they look like in pathology? And here we can see once again the long head of the biceps, and we can see that the biceps actually looks okay. So the biceps doesn't seem to be tendinopathic. It's not enlarged. There are no really dark zones, hypoechoic zones within the tendon. But the problem is more actually on this side. This superior glenohumeral ligament looks enlarged, meaning that the capsule is irritated. And what actually would be really nice now is to switch on your Doppler signal to see whether there is an inflammatory process there, whether you can find neovascularization. The coracohumeral ligament also looks a little bit thickened. And if you would ask me, Marc, how do you know? I think that's a matter of experience. You know that if you scan a lot of structures, and you all have been scanning for quite some time probably now, you build up this internal library, your reference library of normal images. And after you've seen, let's say, 50 normal rotator intervals, once you see a rotator interval with pathology, it really pops up and it really stands out, and you can immediately see that there is a swelling over there. It's hard to quantify actually the dimensions of the superior humeral ligament. So use also the other shoulder to compare in left-right comparisons. Another thing we can see here is a bursa, a effusion in the subacromial subdeltoid bursa. And in the video, we saw that it was only a hyperechoic thin line, but here we can see this effusion. So thickening of the ligaments and also a swelling of the bursa. This is also showing the same thing, only I adopted this image, implemented this image to show you the increase of the coracohumeral ligament. In the other image, that wasn't that clear, so this shows it a little bit better. Sometimes the superior of the coracohumeral ligament can thicken quite a lot. So, and this is definitely also a sign in capsulitis or frozen shoulders. So it's not only about thickening of the ligaments or swelling of the bursa, but like mentioned, it's also about the long head of the biceps. Is it tendinopathic? Is it torn? Because in case of a full tear of the biceps, also check the rotator interval to see if the biceps is truly absent, because you always want to differentiate with the intertubercular groove between Is it anisotropy? Is it a full thickness tear? Or might biceps be luxated to medial? And when you go to the rotator interval and you find the biceps there, then it's probably anisotropy. But if you cannot find it in the rotator interval, it has to be pathology. If there is an instability of the long head of the biceps, there might be some shearing forces between the bone and the biceps tendon, and then the chondral print sign might happen, which is an irregularity of the humeral head due to these shearing and frictional forces. So how does become the long head of the biceps unstable? This might be due to coracohumeral ligament tearing, but also superior glenohumeral ligament tearing, but also subscapularis tearing might also be the cause. And this is the case in this image, and we can see that the biceps is quite high in the rotator interval. Usually it has this oblique position, one tip close to the bone, the other side is a little bit on top of the superior glenohumeral ligament, but in this case, we can see that the biceps is high. There is a tearing of the coracohumeral ligament. We can see a chondral print sign, a sign of instability, and we can also observe that this part of the subscapularis has been torn. So I mentioned frozen shoulder, and the European Society of Musculoskeletal Radiology made a consensus statement, a really interesting article about is ultrasound indicated in a number of pathologies, and 3 was the highest scores, meaning that ultrasound is the preferred imaging technique, and to scan for in case of a frozen shoulder, it actually scores a 0, meaning that it's definitely not the preferred imaging tool. It's actually scored a 0 in 2012, but in 2017 they updated it to a 1. So slightly more evidence, but I will show you some more slides why I think that it's still interesting in these people to scan the rotator interval. But definitely the clinical picture is more important with frozen shoulder people, and the passive external rotation limitations is still the most important sign, clinical cue to think of the frozen shoulder. But when there is a frozen shoulder, there might be some potential musculoskeletal ultrasound features which you have to think of. And that's why I also name them, because you should not overlook or think, okay, whatever. But you really, if you see these, think also about checking the patient's external rotation and yeah, to do that. So next to other signs, today's topic in the rotator interval, we can see thickening of the coracohumeral ligament. The rotator interval becomes more hyperechoic, and you might see an increased power Doppler signal. And also the coracohumeral ligament can thicken near the coracoid process. So not only near the biceps, but also near the coracoid process. And I brought a nice image to show you how this looks like. Here we can see the coracoid process, and this is the coracoacromial ligament, and this is the coracohumeral ligament, and we can see a thickening of this ligament. Usually it's thin and quite hyperechoic, and some people even think that this is the coracoacromial ligament, but it's truly a different ligament, and you can see also that it's really separately and has different appearance in this image due to
I would
this.
chime in, Marc. I know for diagnostics, you're saying maybe clinical picture first and ultrasound second, but also for many of us doing interventions, it can help guide, because one of the standard interventions for a frozen shoulder is an injection, and you can do the ultrasound guided injection at the same visit. It really can help drive and accelerate treatment pathways too.
Definitely. I think that I don't understand landmark-based injections. I think that it's much more patient-friendly to do ultrasound-guided injections, because it's evidence has shown it's less painful for the patient. The patient can also see that the needle is really there where it should be, and this also gives a certain trust of the patient into the therapy. And also the injected is placed on the right spot. So definitely use ultrasound to do your ultrasound guided injections. And last thing I want to just mention is that within a frozen shoulder image, you always have to exclude first certain pathologies to be sure that it's truly a frozen shoulder. And you also have to exclude massive rotator cuff tearing. And we all know that ultrasound is a fantastic tool to exclude these massive rotator cuff tears, because they score a 3 on this consensus statement, preferred imaging tool. Okay, that was a little bit about the rotator interval. I hope that was interesting to you. So let's look at one level deeper, looking at the common extensor tendon, of course involved in lateral epicondylitis or tennis elbow. And the common extensor tendon is actually a combination of the extensor digitorum, the extensor digiti minimi, the extensor carpi ulnaris, and also the extensor carpi radialis brevis. So these are together the common tendon, originating from the lateral epicondyle, and then at one point they transform in separate muscle bellies. And you can see that these have a proximal distal orientation going towards the wrist and the fingers, and so they are truly extensors of this region. One level more to proximal is the extensor carpi radialis longus. This is really separate from the extensor carpi radialis brevis and the common extensor tendon, but this can also mimic lateral elbow complaints, and sometimes you can also find pathologies there. And I actually brought a nice image with me to show you. And we can also see one level deeper into the depth, close to the radius, the supinatal muscle, and look that this is a oblique course of fibers, meaning it has a different function. It's not an extensor, but this is a supinator, pronator for the forearm. Really close to the bone, really close to the joint is this common extensor tendon. And because the lateral epicondyle is roughly there, here we can see the joint between the humerus and the radius. And of course, where we have a synovial joint, this is a synovial joint, we always have a capsule, and also reinforced with ligaments. And in this case, is reinforced with a collateral ligament. And this collateral ligament is really close to the tendon, and they have a similar appearance. So this is a pitfall that you might confuse ligament for tendon or vice versa. So let's have a look at how to scan. We're going to place the transducer on top of the lateral elbow. If this is 90 degrees, if this is 0 degrees, the transducer is roughly 70 degrees on top of this lateral elbow. What do we see? We see the lateral epicondyle. It slopes down to the capitellum of the humerus. And on top of it, we can see the tendon, the common extensor tendon. Observe that the tendon is flat. It's a horizontal line. This is important to note. Because with tendinosis, you might have a swelling. With tearing, you might have a convexity. This is the joint between humerus and radius, and this is the radial head. Please observe this dark zone here. This is the transition zone between the tendon and the muscle fiber. So this is the musculotendinous junction of the common extensor. And in the depth, of course, I mentioned that this is the humeroradial joint. We can find also the collateral ligaments in the capsule of this joint. It's important to scan any proximal to distal orientation, to scan every fiber of the tendon like this, but also in going down and up again, so that you have all parts actually of the tendon. Here we can see fiber orientation, which is a little bit different. This is the supinatal muscle, and it's right underneath the extensor muscles right there. I'm going to hold the patient's hand and make a pro and supination, as you can see, and this gives you a view on the radius pro and supinating within the humeroradial joint. This is interesting to see whether there are bony changes due to osteoarthritis, due to degeneration, but also in case of suspected fracture, you could, of course, also pick it up right there. Okay, so let's continue with the pathology of this common extensor tendon. And Lateral elbow pain is quite common, and one of the main causes is indeed the tendinosis or the tearing of the extensors. But there are some differential diagnoses. Please also think about the cervical thoracic spine, or the cervical spine. Think about muscles in this shoulder region, and also in the cervical thoracic spine region. So that's important to screen. But also think of less common causes, for example, joint problems, synovitis, osteoarthritis, lateral collateral ligament injury. This is also important to filter out. And a very interesting one is the posterior anterosseous nerve entrapment. This is a nerve, a deep branch of the radial nerve, which is in the supinatal muscle, and this can impinge this nerve, can entrap, and this can mimic actually these lateral elbow problems. So also important to look at, and not to be missed is the osteochondritis dissecans. So, okay, so let's look at this number. This is a 3, scoring a 3, meaning that musculoskeletal ultrasound is the preferred imaging tool to use when screening for lateral epicondylitis. So you don't have to do other medical imaging. Ultrasound is the preferred tool. So I brought a number of images with me, and this first image, we can see some longitudinal and some short axis views without and with color Doppler, or power Doppler actually. And you can see that this horizontal line I mentioned is not horizontal, but there is a small convexity, a thickening of the tendon, and this is due to a swelling within the tendon, meaning a tendinosis. But also look at these hyperechoic parts within the tendon, and these are signs of a calcification. So this is a calcific tendinosis. We can also see that other parts of the tendon are quite hypoechoic. So this is definitely tendinosis, and probably there will also be some micro tearing right there, but this is hard to see due to this calcification. And it's also an inflammatory process because we see a very positive power or Doppler signal. And I promise you a pathology of the extensor carpi radialis longus. This is the one. And we can see that there is a calcification within the muscle, really close to the lateral epicondyle. So this is also one of the reasons why you have to scan up and down to proximal and to distal to scan the full tendon complex and also surrounding tissues, because they are really closely linked to each other, and you don't want to miss this. And we can see that this is a calcification, as it is hyperechoic, bright white with a shade underneath, acoustic shade. So this is a calcification. Again, another case, we can see that the tendon has swollen again. This is a swelling. We can see also that the tendon is a little bit darker, more hypoechoic, and especially this spot is quite hypoechoic, and this seems to be a tendinosis. It's not tearing, I would say, because I still see some fibrillar pattern. You see some connection right there, but it's definitely swollen. Therefore, this thickening of the tendon, this convexity of the tendon, but also this hyperechoic appearance of the tendon. And it's not only about the tendon, there's also a bony change. Look at the irregularity of this bone right there. This is an osteophyte, real close to the humeral radial joint. And we would expect it to be smooth, but it's like spiky, like a osteophyte. This is a really dark zone, and this is a severe tendinosis. You can see, of course, the swelling and that it's really, really dark. See the difference with this. This is how it should be. And I would not say that I'm really convinced that there is no tear here. I think that there will be some tearing right there. And so this is definitely a swelling within the tendinosis and probably also a tear of the tendon. Tearing of the tendon sometimes goes together with this inflammatory process. Switching on the power Doppler signal can give you more information about the inflammatory process. and potentially also for your clinical decision making. Do I want to inject? Yes or no? Under ultrasound guidance, yeah, this could help you as well.
And as a beginner, my level of MSK sonography skills are nowhere near yours, Marc, but I always use, most of our patients have the other side, like you alluded to. When I think there's pathology, I don't have the internal library of thousands of cases. I just always compare to the other side. Do I think that this is a real finding? And then it helps convince me.
That's a great tool to just simply compare, and people also like it, right? So they like to be educated in a way that you can say, see, this is on the left side, this is on the right side, and this, yeah, so they also like it. So it really helps you, but I think also helps the patient. Right, so this is a severe partial tearing. I just showed you some cases with a convex tendon. Now we can see a concave tendon, and if there is a concavity in a tendon, then you have to be sure that there is a severe tearing in the depth, loss of intra-tendon stability, and this is the case actually in this region right there. We don't only see a tearing of the tendon, but also the collateral ligament in the depth is torn. So this, I would say, is a severe partial tear. And this is a full thickness tear. So now from bottom to top, we can see that there is a anechoic zone. There seems to be no tendon connection anymore with the bone. There is a effusion right there. This effusion comes from the joint, from the humeroradial joint. And this is the tendon stump, the fracture of the tendon retracted to distal. So this is your full thickness tear. So now you saw actually a lateral epicondyle. Could be numerous causes. The clinical examination, I would say, is not able to screen between these different types of pathology, and I think that really matters for your clinical decision making and for your prognosis to know the details of the tendon. Okay, I just want to invite you to sonoskills.com. We have some really nice, cool topics, so maybe it's also interesting to you. So the infrapatellar region is the last region I just want to touch on today. So this is the patella, and the infrapatellar region consists, for in this talk, mainly out of the patellar tendon, which is originating from the medial and lateral parts of the patella. So don't forget to scan these as well. So not only in this deep portion of the patella, but also on the sides. And then it's quite broad there, and then it goes all the way to distal to the tibial tuberosity for its insertion. So the weakest spot actually is in the proximal patellar tendon, on the level of the origin of the patella, and then the deep part or the deep medial part. So these are the two main spots affected in most cases. So pay extra attention to that spot. So also meaning that you really have to scan from medial to lateral in order to see the full tendon and to observe this deep region on both sides, laterally and medially. There might also be some joint fluids or fluids around this region if you are scanning the patellar tendon. This could be a pre-patellar bursa or bursitis. This could be a superficial infrapatellar bursitis. This could be a deep infrapatellar bursitis, or this could be a swelling within the knee joint because the condyles are in the depth, and of course also synovial fluid is there to give nutrition to the hyaline cartilage. So let's look at this last demo of this talk and place the transducer first in longitudinal view over the patellar tendon and connecting the patellar bone right there. And we can see the patellar tendon right there. And I'm going to scan from medial to lateral to scan every part of the tendon. And if I've done that, I'm going to scan from proximal to distal to follow the tendon all the way to its insertion at the tibial tuberosity. Underneath the tendon, we can observe a fat pad. This is indeed Haffa's fat pad. And in the very depth, sometimes you see a glimpse of the femoral condyle right there. That's the femoral condyle. So what we do want to see is that the tendon is horizontal line in the depth, also fairly horizontal in the top. And this is actually a small pathology. We see a tearing of the patellar tendon right there. This is a longitudinal partial tearing. We see a anechoic zone within the tendon. This is okay, but this is definitely a tear. And this is actually a professional football player, and I'm meaning European football, soccer, and who we scanned. Okay, so this is the tibia, a little bit more to distal. We can see a little bit fluid collection there. This is the deep infrapatellar bursa, and this is normal, this small amount of physiological fluid. It's there to reduce the friction between the bone and the patellar tendon. And we can follow the patellar tendon nice all the way on top of the tibial tuberosity. See how smooth and gradual it slopes down. I have pathology images about that later on, so it's important to note right now. Moving back up to proximal, and then at one point you can also turn the transducer, rotate the transducer 90 degrees, and look at it from a transverse perspective, like this, for example. So placing the transducer on top of the patella, we can see the sliding off the patella, we can see the cross-section of the tendon, and within the tendon there, we can see again this pathology he had, this little tear, partial tearing, and you can see that the tear is only quite, it's not very wide, but it's very long. And we can see a nice boundary of the tendon, and in the depth, indeed, the Haffa's fat pad. Okay, so let's follow it down to distal. That I will do probably right now. Yes, following it down to distal. And here you can see the tibia and some fluid again, the deep infrapatellar bursa right there. And we can see the insertion of the patellar tendon right onto the tibial tuberosity. And that is right here. So these are the last fibers, and there it's gone. Okay. So how does it look like? The last slides about pathology. See the consensus statement scores in 2012 and 17. You can say that the patellar tendon scores a 3 for screening on patellar tendinopathy or a jumper's knee or tearing. For Osgood-Schlatter and Sinding-Larsen-Johansson disease, more juvenile pediatric conditions. For bursitis, it scores a 3, meaning all the preferred imaging technique, MSK ultrasound. For Haffa's fat pad, it is a little bit more tricky and difficult. This scores a 1, so it's not the preferred imaging tool. So let's look at this patellar tendinosis. This is quite thickened, but if I move from medial to lateral, you can see a dark there zone, a dark swelling there. And this is a sign of a jumper's knee, a small, not so much a severe jumper's knee, but a subtle jumper's knee. And you can see that indeed it's in the depth of the tendon, the weakest spot. The swelling in the tendon can not only happen proximally or in its whole stretch, but also isolated quite distally. It happens, or the thickness is quite okay, but then we see a thickening of the tendon right there. With some dark spots. So in this case here, we can see a definite tendinosis. There is no tearing because we can see that the fibular pattern of the patellar tendon is still intact. This is a partial tearing. We can see that there is a convexity right there. It's also round, a concavity, let's say like that, right there. And a swelling right there. So this is increased in thickness. Usually you would expect it to be like that, but it's much bigger. We can see hypercoic zones, tearing in the tendon, also some hyperechoic speckles right there. And always, always, always do your longitudinal and short axis scanning. This goes for all ultrasound, as you know, to not only know more about the length of a problem or the thickness of a problem, but also the width of the problem. So have a view on the 3D aspects, but also for confirmation. And of course, this is a severe inflammatory process. We can see a full thickness tearing of the tendon, patellar tendon, a complete tearing, and we can see two tendinous stumps right there with a total gap in between. And you can see also with the obliquity of the parts that this is a true and severe defect. This is a normal view. You can see a smooth bone, but here in the tibial tuberosity, we can see quite an irregular bone, and this is a sign of Osgood-Schlatter, and we can also see that the tendon is quite dark and less organized, a little bit more chaotic. So this is Osgood-Schlatter disease. I mentioned indeed the effusions around the patellar tendon. This is a superficial bursitis, infrapatellar bursitis, the superficial one on top of the tendon. This fluid you should never see. Because if you see it, it's pathology. But in the deep portion, you will see some fluid in a physiological state. But in this case, it's too much fluid. It's way too big, actually. So that's the reason why we say that this is a deep infrapatellar bursitis. And my last pathology slide is tendon looks fairly okay, maybe some thickening right there. But underneath half a fat pad in the depth, we can see a deep fluid in transverse and also in longitudinal view. And this is indeed fluid from the joint. Okay, so thank you very much. So this was actually my presentation. Back to you, Aron.
Yeah, thanks so much, Mark. We're going to have a bit of time, I think, left for a live Q&A session. So we can use some of that time here, and please use the Q&A tab on the bottom, and you can get an answer today for what we can get through, and then certainly other questions you can follow up with Mark afterward. We wanted to kind of round out the presentation by just sort of summarizing, ways that Mark showed that ultrasound can help in your MSK practice. I think you'd agree it really narrows the differential beyond the clinical exam by really looking into the joints and the musculoskeletal tissues and seeing them dynamically in real time and their function. You can really replicate some of the symptoms that patients are having and watch exactly what's happening. And that allows us to make these confident diagnoses in real time when we're seeing the patient, and often on that first visit. So when people are coming in for a consultation, rather than guesswork and referring out for additional imaging, frequently that diagnosis can be made and documented. And one of the things that particularly that Clarus excels at is being able to capture those images in an archival system, being able to share those with other practitioners too. It's really great to then help the downstream patient management flow. And one thing, I don't know if you found that, Mark, but being able to share the images with patients and show them the pathology, I think it's pretty transformative. Patients love to see inside their own bodies to sort of demystify what's happening and what they're experiencing with their pain and their symptoms, and particularly in an outpatient practice where some of our other physical therapists have been using these devices, and in the MSK practice world, it helps to kind of build this relationship long-term, and it gives the patient something to work towards, to practice towards of improvement, and watching, for instance, their bursitis reduce or their tendon size change. People love it, and it really makes everybody happier, both practitioner and patient.
Yeah, I fully agree with that. So I told you something about the Mediterranean way and the Anglo-Saxon way of scanning, and the way as the reason why I stand behind the patient is actually so that the patient has the ability to look at the screen as well, and to make it also a sort of education to motivate the patient to do his exercises and to understand what the exact problem actually is.
That's really great. Yeah. To just show, I'm not an expert at MSK imaging, right? I'm an emergency physician by day, so I don't do as detailed. I'm definitely on the early part of the learning curve, but I was hoping you could talk me through just how, this might look in a bit of a more detailed scan, and kind of what it might look like for a beginner. Say if we try the knee, I know you focused on the patellar tendon, but you know, the knee has so many other structures too. What it looks like when I scan a knee, I'm used to looking primarily just at joint diffusion, and I'm learning how to identify other features in the knee. Maybe we can just do a quick survey scan. Certainly we can't go into depth. We don't have the time to do a full in-depth knee scan, but what are like the main components of the knee that you would be scanning? Usually I start in the suprapatellar region when I'm doing a full knee scan. Is this where you start also for your knee scans?
Yeah, so you can start indeed in this suprapatellar region. You're doing this correctly with having the patella on the right side of the screen, and attached to the patella we can see indeed the quadriceps tendon, also the layers of the quadriceps tendon. So the image is absolutely magnificent, the quality, and we can see underneath the quadriceps tendon actually the suprapatellar recess, a little bit filled with fluid right here. And this is definitely interesting to spot to start your assessment of the knee joint. Yes.
And then you kind of fan over the tendon from lateral to medial, right? You're making sure, like you mentioned, really get the whole tendon all the way across.
Yeah, that's important to scan the whole region, not to forget places, and look at the integrity of the quadriceps tendon, but also at the amount of fluid collection, or what's inside the fluid collection, because sometimes you can also see some synovial proliferation or some loose bodies right there.
Right, and so there's maybe a trace effusion in the suprapatellar bursa right there. Yeah, okay, and then always making sure we go in axial 2, right, in the short axis, scanning through. Yeah, great.
Fantastic.
A little bit of fluid. Great. And then you know, what's new to me is coming down the joint too, doing kind of the joint. I don't routinely look, you know, and part of that is because I've never had access to great image quality, but being able to really evaluate the menisci, is that what I'm looking at right here?
Yeah, we can see the medial meniscus in the joint space. We can see overlying the medial meniscus, we can see also the collateral ligament complex. There is a superficial part, but also a deep part of the superficial ligament of the medial collateral ligament complex. And both parts should be assessed, the superficial and the deep part. And now in this specific image we're seeing right now, you can see beautifully the deep part of the meniscofemoral ligament, the deep part of the medial collateral ligament complex. It's the hyperechoic ligament running from the meniscus towards the left of the screen on top of the hyperechoic bone. So this is beautiful to see, and he looks like having a great meniscus. So
yeah, okay, he'll be happy to hear that. Yeah, and then the lateral, we kind of the same thing on the lateral, right? So kind of take a look here.
Yeah, so the lateral side is a little bit more difficult from a meniscus point of view, but laterally you can really see the collateral ligament quite well, and some fluid collections around the ligament.
Right.
Yeah.
So for someone coming in with knee pain, you know, being able to assess some of these structures that we usually rely on these clinical tests that I find have pretty poor sensitivity and specificity, even in the best hands, to just add the imaging to augment my physical exam is so powerful to actually see, you know, really what's going on. And this is the scan you were doing, right, showing us through with the patellar ligament, right? So here we go. There's the patella. And see, after I like to operate by the see one, do one principle. So now I saw one. So here's my patellar ligament, right? And I'm going to make sure to sweep all the way across. Of course, I would probably be going slower with in a real patient encounter to really make sure I'm looking for subtle findings. And then coming down all the way to the tibia here, the insertion.
Yeah, fantastic. If you want to improve the image of the patellar tendon a little bit, then you can apply a little bit more knee flexion. So a little bolster underneath the knee will stretch the ligament. And with this, the image quality will be better. But your technique of moving is great. It's good.
Yeah, beautiful.
Yeah, this is better. Great.
And this is what you said was really important to assess the posterior aspect of that patellar tendon as the primary source of pathology. Great.
Yes.
Great. Yeah. What a powerful tool. Well, thanks so much for leading me through that. That's great. Yeah. Great. Well, with our last few minutes, we're going to save some time for Q&A. I'm going to hand it back to Janez to take us home, and then please use the Q&A tab on the bottom, and we will get to as many questions as we can at the end here.
Thank you so much, Dr. Frankel, for the amazing demo, and Mr. Schmitz for taking us under the skin to look at high definition imaging of anatomy in the shoulder, elbow, and knee. Just before starting our live Q&A session, and again, you can use the Q&A icon at the bottom of your screen to ask your questions. I would like to take a minute first, though, to introduce you to Clarus HD for the highest definition wireless ultrasound imaging. Clarus HD linear devices are specifically designed for clear MSK imaging and deliver several advantages. Clarus is unrivaled for near field and high resolution imaging in a handheld device. This best-in-class imaging is what you need to get detailed, real-time ultrasound images of muscles, joints, ligaments, tendons, and cartilage, as you saw today, to quickly diagnose MSK injuries, guide management, and also for safe ultrasound-guided procedures like PRP injections. The secret lies in each scanner with 8 beamformers that deliver the image quality only found in traditional systems, but at a fraction of the cost. And with artificial intelligence to replace complex knobs and buttons, it's as easy to use as your smartphone. Clarus is also wireless, freeing up space with zero footprint for portability from patient to patient in a variety of settings, from the clinic to the field, for example. You get free movement with no more wires getting in the way and touching your sterile prep area. And with no wires, Clarus is also so much faster to clean and disinfect or fully encase in a sterile bag. Only Clarus delivers linear wireless scanners with a free ecosystem that includes free apps for your iOS and Android devices with free updates, unlimited cloud storage to capture and manage exams, and for unlimited users at no additional cost. Clarus is so affordable also with no subscription fees. You can use a single device to share it among physicians in your practice. Now, just before we open up the floor to questions with Dr. Frankel and Mr. Schmitz, we have a quick poll question for you. We'd love to help everyone continue their journey in bringing handheld ultrasound to their practice, so please do complete this poll if you'd like additional information. You can select any that apply here. So if you'd like additional information, please do select one or many of these options. You saw some tutorials today that were narrated by Dr. Schmitz. If you'd like us to send you the original Clarus classroom videos, we'd be happy to do that. If you'd like to request pricing, we'd be happy to help you and provide you with a quote. We do offer Clarus in over 90 countries worldwide, and pricing is available in a number of currencies. So please go and select that option if you'd like to understand local pricing in your region. If you'd like to speak to one of our experts about handheld and wireless ultrasound advantages, we'd be happy to do that. If you'd like to book a Clarus demo to see live scanning in action with one of our sonographers, please go ahead and select the demo option. Or if you'd like to discuss features and compare it to other solutions that are available in the market, please select that option. There are so many people voting. I'm just going to give you 5 more seconds here to request for more information from our team. 5, 4, 3, 2. Oh, I'll give you 5 more seconds. There's so many people trying to get in and vote here last minute. 5, 4, 3, 2, 1. And again, if you don't have a moment here to fill out this poll, you can go to our website to request more information at clarus.com anytime. All right, we will close the poll and we will move on to our live Q&A session. I'd like to welcome back Dr. Frankel and Mr. Schmitz to answer your questions. Please use the Q&A icon in the menu bar at the bottom of your screen to ask your questions. And Dr. Frankel, I'll invite you to moderate our live Q&A.
Great. Yeah, I'm going to jump in because we don't have a ton of time and a lot of questions. So anyone we don't get to, we'll follow up with an email with you. So please just keep popping them in. So first one, Marc, do you consider, I think you already answered this, but the rotator interval mandatory in routine shoulder scanning?
I always do it actually. So it's not standard protocol, but I adopted it as standard protocol for me. And I really advise other people to do this as well.
Great. Yeah, I think you made a pretty compelling case there. How long does it take to get comfortable scanning particular joints?
Oh, yeah, this is a little bit depending on which structure you want to scan. There are structures like, for example, a patellar tendon, which has quite a steep learning curve. Let's say 20, 30 scans, then you'll do okay. But there are also, but let's say most structures, research has shown that you need 100 times scanning of a particular structure to have sufficient diagnostic accuracy. And this seems a lot, but if you do it 10 times a week, then within 10 weeks, you are already real high in your learning curve. But if you only do it 2 times a week, then it will probably take you 50 weeks, almost a year. So it's all about, ultrasound is about experience, doing it a lot. And let's aim for this 100 scans of a tissue.
Nice. There's a question. You don't do injections, right? In your practice, there's a lot of questions about injections.
I do injections, but at this time, I mainly focus on shoulder injections, ultrasound guided, and sometimes also in other parts, but it's now mainly in shoulders because I see a lot of shoulders currently.
Great. So, one of the questions, I'm going to group together a bunch of questions about where do you do injections, or where are you supposed to for adhesive capsulitis?
So usually we take a posterior approach to the cleanohumeral joint, placing the patient on his non-affected side. Arm is to the non-affected, towards the non-affected shoulder, and then having a lateral to medial approach from dorsal, ultrasound guided in longitudinal, and then really aiming for this triangular shape near the labrum and the glenoid cavity. So this is where I place the injection. Yeah.
You're going intra-articular then?
Intra-articular, yes. You could also
I had
do
read
it,
some studies. Oh yeah, I had read some studies about actually injecting near the rotator cuff interval, but no one really knows yet about where the best place to do it is.
Yeah, so you can definitely. So I don't do it that way. It is possible probably to do it that way, and to me the easiest spot to do it. So for scanning the rotator cuff interval, it's more about diagnostics, and treating, I take this posterior approach.
Okay, great. Is there any conditions for the hip where musculoskeletal ultrasound really shines?
Oh wow, yeah, a lot. So I think that the hip is so I teach a lot of courses, right? And the hip is by far the least popular joint within courses because people think it's a little bit difficult. But once they start doing it, then they suddenly are amazed with how much you can see and how much ultrasound can do within the hip. So let me name a few things. Adductor problems, especially in athletes, gluteus medius and gluteus maximus problems, and the trochanteric region in elderly, but also in athletes. In the joint in elderly with degeneration, but also with total hip replacements. Hamstring problems in athletes, but also in, yeah, well, so the list is long and you can definitely use within the hip region. Yeah.
Great. Let's see. CPT codes are definitely CPT codes in the US. There's a whole, we could probably give a whole talk on that and we could follow up with more information. What do you think is the best way to learn how to be proficient at doing this kind of scanning?
Yeah, so those are a few things which I can really recommend. First of all, do a course, and you need to really get your hands dirty with gel and start doing it under a certain guidance and tutoring of people who know what they're talking about and who have experience. So doing a course, that's one. Then studying, study your articles, study cases online. For example, go to ultrasoundcases.info. It's a free website and you can find heaps of pathology cases right there for free. If you study anatomy in the beginning, because anatomy knowledge is really important and crucial for a good understanding of MSK ultrasound. And then if you're good at anatomy scanning, then you can grow into the pathology field, but anatomy is really important. And last but not least, finding a buddy can really help. So if you do it together, then you can challenge each other and you can practice and give each other tips and tricks. This also really helps. To my experience and what I hear from all people is that it's a nice experience, a nice road. You will be amazed about how many misconceptions you had in the past. And with ultrasound, you have a new view on biomechanics, on clinical examination, on pathologies, about the functional relationship with anatomy. So it's a really cool trip which will change you forever.
100%. I wish I learned it when I learned my clinical exam skills.
Right?
It takes out the guesswork. Yeah.
Yeah.
Great. Yeah. Well, we're at the top of the hour here. Thank you all for participating from all over the world. All of these questions that we weren't able to get to, we'll definitely follow up. Either Marc or myself or someone from our team will be able to follow up with you.
Yeah, thank you so much, Dr. Frankel, for moderating our session, and Mr. Schmitz for all the wonderful answers. We would like to thank both of you for all your insights, and also a very big thank you to all of you for joining us today. If we didn't get to your question, we will get back to you in the coming days. As well, you will all receive a link to the webinar recording in the coming days by email, as well as a PDF copy of today's presentations. Thank you so much for joining us today, and we wish you a very wonderful rest of your day. Thank you.
Great. Thanks so much.
Bye-bye. Thank you.